Is everything visible from my side?
So should I
Yes,
start?
sir. Yes, sir. We are live.
Yes.
Okay. So good evening, everyone. I am Dr. Jairam Navde, a consultant in critical care medicine at Raheja Hospital, Mumbai. I welcome you all to today's webinar on very important topic, that is how important is protein in the ICU, when, how to monitor, and which protein. First of all, I would like to thank Dr. Sanjit sir and ISPEN for allowing us to conduct this webinar. Today I am going to invite Dr. Subal Dikshit sir. He is the very well known personality in the critical care medicine. He to tell us about the upcoming ISPEN Pune National Conference. He is
Okay,
very well known personality in the critical care medicine. He is the director of critical care medicine at Sanjeevani Hospital, Pune. He is also a past president of ISCCM and past chancellor of ICCCM. He is also a chairperson of ISPEN Pune branch. Over to you, sir.
okay. Thank you, Jairam. Thank you, Ispen, and thank you, Sanjeev, for allowing me to speak a few minutes before Swapnil takes over and gives this lovely presentation regarding the importance of protein, which is a very important topic. I'm here just as on behalf of the ISPEN as well as the chairman of the ISPEN Pune branch. I welcome you all to Pune. We'll be having the 19th conference of the annual Indian Society of Parenteral and Enteral Nutrition. We are going to have it on the 30th of November and the 1st of December. This is going to be a Saturday and a Sunday. On a Saturday morning, in the first half, we'll be having the nutrition boot camp, which will be the nutrition workshop, which will be having a 4 breakaway sessions along with pro-con debates, which will there. I'm going to introduce the ISPEN oration from this year onwards, where the ISPEN oration will be an important aspect where I'll select and try to get a renowned personality who has done original work in India as far as nutrition is concerned. And of course, we'll be having various scientific sessions, panel discussions, free papers, as well as posters, which will be there. And that session will be running on a Sunday whole day. On a Saturday evening, we'll be having the inauguration session, and then that will be followed by one small dinner where a get together and followed by a few scientific sessions. The venue for this, I've already seen it. We'll be having at the Nagar Road. It will be held at the Novotel, at the Novotel in Pune, which is quite well connected by metro. It is very near to the airport, just about 10 minutes drive from the airport. Quite centrally located, well connected. A lovely weather to be in Pune in November, December, with the winter just starting in. We have got a lot of sightseeing. So I welcome you all to Pune for this lovely academic feast. Again, thank ISPEN for giving the opportunity to host this ISPEN 19 conference in Pune. I'm having the first organizing committee meeting of the ISPEN Pune along with the organizing team tomorrow itself in Pune. The brochures also is being prepared, which will be sent to all the ISPEN members soon from MedVents, and MedVents will be the events will be handling the entire conference here. Okay, so thank you. Welcome you all to Pune and see you all in Pune. And what I would just speak a few words on what definitely is an important topic what Swapnil is going to cover, that the importance of protein. It's a very important topic which you must understand. There have been a lot of debate about exactly what is the best number of which you should try to target, how much protein, when to give, how to give, which are the patients you must optimize it in the right way. And more importantly, as what Jairam said, that importance of delivery should be monitored and how the protein should be monitored. That's a very important aspect of it. So without wasting much time, again, welcome you all to Pune, and I welcome Swapnil to take over from me. Thank you very much.
Thank you, Subal Dikshit sir, for giving us this time on a very short notice. So thank you, sir.
I'm sorry I have to leave because I've got another webinar again at 7:30. Yeah,
Okay, sir.
thank
Okay.
you very much.
Okay. Thank you, sir. So, to all the participants, kindly attend this very important webinar and very important and informative webinar till the end, so that we can have a fruitful discussion. And if you have any queries, kindly ask in the chat box. Today's session is moderated by Monica Patil. She has a well experience of more than 12 years. She has done MSc Critical Nutrition and Dietetics. She is also a treasurer of ISPEN Chhatrapati Sambhaji Nagar. She is also a executive committee member of IAPN Chhatrapati Sambhaji Nagar. She is also a national diabetic counselor and nutrigenomic counselor. She is also director of Lemon Green Services. She also does the leading kitchen auditor and visiting dietitian at Johnson and Johnson since 5 years. Over to you, Dr. Monica Patil.
Thank you, sir.
Your voice
for-
is not audible.
Now audible?
Yes, yes.
Okay. Thank you, sir, for such a nice introduction. Happy to be here. Welcome you all. It's my pleasure to be moderator for this session. Thank you, Team ISPN. And it's my honor to introduce Dr. Swapnil Khadke, sir. He is an intensivist physician, head of the Department of Critical Care Medicine Department at Fortis Hiranandani Hospital, Vashi, Navi Mumbai. He is treasurer of ISPN Mumbai branch, and he is co-author of Clinical Approaches to Basic and Cardiac Intensive Care. He is also executive committee member of IMA Ulve, Navi Mumbai, and he has extensive experience and research in the field. Welcome you, sir, on the panel. Today's topic is how important is protein in ICU, when, how to monitor, and which protein. We all are eager to listen such an important topic. Over to you, sir.
Thank you very much. I'm very much thankful to this platform, specifically for SPEN Mumbai branch, and definitely we all will take at earliest and as possible as benefit of such sessions, and we will continue all those webinars. So I will not waste time. Straight away, we will go ahead and we will try to keep it simple as it possible. So to start with introduction, severe protein calorie malnutrition, that is PCM, is major problem in critically ill patients due to increased catabolism, chronic wasting syndromes. And this PCM leads to lots of complications, including worsening mortality and morbidity rates. Here are detailed ISPEN guidelines for use of protein in ICU, focusing on type of protein, timing, amount, and monitoring. Why it is so important to give so much importance to this malnutrition? Because many of times patient might have this calorie deficit or protein deficit before landing up in critical illness, or it could be the sole reason why patient is having immunocompromised or any other state which is leading to this disease state, or you can say compromised state. And definitely, when we are treating the patient, it is not only the medicines, but also the nutrition aspect is very, very important to fasten the recovery, or sometimes it may help in reversing the disease whenever it is possible and if body is showing all the response. So types of protein, specifically in enteral nutrition, that is standard polymer formulas. These contain whole proteins and are suitable for most ICU patients. They provide a balanced amino acid profile and are usually well tolerated. Peptide-based formulas, definitely these contain hydrolyzed proteins, which are again peptides and are used for patients with malabsorption issues or severe GI dysfunction. They are easier to absorb and can be beneficial for patients with compromised gut function. Why this is so? I mean, peptide we are always and always emphasizing, because we cannot have high amount of protein that we usually can prescribe to any of patients or particular to the person who is gymming on all those activities. But here we have compromised patients which are landed up in ICU with any reason, and that's why we require something which should be easily digestible, and it should get patient should get benefited not only in uh, not only in disease treatment but for the further management. Now, coming to the next point, that is specialized formulas. These may be required for patients with specific conditions such as renal failure, that is low protein, low phosphorus, or liver disease, that is branch and amino acids. Wherever liver disease, we have to accept or we have to prefer branch and amino acids. And in renal failure, even if we are seeing low protein and low phosphorus, it is little bit changed whenever there is whenever patient is on hemodialysis. That means there, in fact, we have to increase the protein. Types of protein, that is parenteral nutrition, will continue. Parenteral nutrition involves delivering nutrients directly into bloodstream. It is used when enteral nutrition is not feasible. Amino acid solutions provide a balanced mix of essential and non-essential amino acids tailored to patient's needs. This parenteral nutrition is also important aspect of it, because every time we are preferring enteral nutrition, but parenteral nutrition come in a picture when we are not able to go for enteral nutrition, or there are some relative or specific contraindications for enteral. Okay. When to start enteral nutrition? Early phase, that is first 3 to 7 days, which is preferred as per the guidelines, which is proven as per the studies and articles. So enteral nutrition earliest start within 24 to 48 hours of ICU admission if patient is hemodynamically stable. Parenteral nutrition, delay initiation of parenteral nutrition until after first 3 to 7 days if enteral nutrition is insufficient or contraindicated unless patient is severely malnourished or at high nutritional risk. Amount of protein, definitely. Amount of protein, that is aim for minimum of 1.3 grams per kg per day of protein. Some patients, such as those with burns or severe trauma, may require higher protein intake, up to 2 gram per kg per day, to support healing and recovery. Here, even if we are having some values like 1.3 or 2, that is considered as reference values, and we have to individualize as per each of patient, and our clinical judgment come in a picture. Why? Because whenever we are saying 1.3 or up to 2, we can increase to 2.5, and if when to start, we can reduce the number less than 1.3, definitely. So whenever we are there is some called as some 30%, 40%, 20% of that calculated protein should be started, and should be reached to the our desired amount of protein what we have calculated within 3 to 4 or sometimes 5 to 6 days, depending on our clinical judgment and patient requirement. So energy intake, initially provide around 70% of resting energy expenditure, that is REE, gradually increasing to meet full caloric requirements as tailored. Sorry, just 1 minute. Oh God, very sorry. I'll repeat this point. Energy intake, that is initially provide around 70% of resting energy expenditure, gradually increasing to meet full caloric requirements as tailored. Okay, so resting energy expenditure is something that we have to calculate. Whenever we are calculating all these things, we have to consider lots of factors, that is BMI or the weight, actual body weight, or ideal body weight. After this calculation, definitely, again, 70% of resting energy expenditure, even if we are saying, we should not, even if it is a we have to take it as a reference value, that's 70% of total. And gradually, we have to start with slow dose and slowly increase in terms of calories and proteins, everything. So monitoring and adjustment. Clinical monitoring is the most important thing that everyone can do. Regular assessment of patients' overall clinical status, including fluid balance, glucose levels, liver function test, and signs of overfeeding or underfeeding. Monitor GI tolerance for enteral nutrition, including checking gastric residual volumes, abdominal distension, bowel sounds, and stool output. So these are very, very basic things. wherever we are having regular assessment, not only on daily basis, but whenever you are having other than daily basis, you can have vigorous monitoring. Now, whenever we are seeing including fluid balance or glucose levels or LFTs, signs of overfeeding or underfeeding, we don't have to aspirate the RT as a as we were doing in previous days. Now recommendation is once in 24 hours is fine enough. But if there is gastrointestinal tolerance, or there is distension of abdomen, or there is bowel sounds which are not being detected on this auscultation, or stool output, I mean bowel not open since couple of days or more than couple of days, then definitely you can have more aspiration from RT. Now these glucose levels and liver function tests, these are always parameters for monitoring, but definitely we have to rule out any if there are any other causes. Nutritional status. Use validated screening tools such as Nutrition Risk Screening 2002 or Nutri-Score to assess patients' nutritional risk or status. So, in whenever we are doing all this thing, we will require that calculations, and definitely there is a big role of our dietitian department. They are going to help us in this nutritional status evaluation. Indirect calorimetry, when available, use indirect calorimetry to measure patients' resting energy expenditure to tailor energy provision accurately. If indirect calorimetry is not available, use predictive equations to estimate energy needs, but start with a conservative approach, that is 70% of estimated needs. Now, this indirect calorimetry, when we are speaking, it looks very fancy, it is very accurate, or you can say minimize the errors, or it will direct us. But practically, indirect calorimetry many of times may not be available at our center. So whenever it is available, it is a gold standard and we have to use it. Now, coming to the biochemical monitoring, it will measure urinary nitrogen excretion to estimate nitrogen balance and adjust protein intake accordingly. This is also one of the best methods because around 6 gram of nitrogen will be will have values around certain amount of protein, and that is helpful for the calculations. Regularly check up the serum albumin, pre-albumin, and other markers of nutritional status, although they can be influenced by factors other than nutrition in critically ill patients. Now, whenever we are dealing with critically ill patients, anyways, albumin and all these markers are helpful not only for this nutritional monitoring, or but not only for the nutritional monitoring, but also for the disease specification or progression or prognosis. In both the ways, this is going to help. So we always can use these parameters, which we are not doing only for this monitoring, but also uh, other aspects in our treatment or management. Practical implementation of whatever we have discussed is initial assessment. Evaluate patient's nutritional risk and current nutritional status upon ICU admission using tools like NRS 2002 or Nutri-Score. Start enteral nutrition, that is initiate enteral nutrition within 24 to 48 hours if patient is stable. Use a standard polymer formula initially. For patients with specific needs, for example, malabsorption, consider peptide-based or specialized formulas. Monitor tolerance and response, that is regularly assess patients' tolerance to enteral nutrition, including GI symptoms and residual volumes. Adjust nutrition plan based on clinical response and the tolerance, definitely. Adjust protein and energy intake. Gradually increase protein and energy intake to meet target needs based on patient's clinical and metabolic response. See, this certain point, I mean to say patient's clinical or metabolic response is something where our clinical judgment, clinical assessment day to day or multiple times in a day, night, who is standing or having that bedside clinical assessment will be having major role. And whatever reference values or whatever guidelines are saying, consider it as a reference value, individualize the patient, individualize need of the patient. What is your management? Anticipate the further worsening of the patient if it is there in picture in this setting, and accordingly modify the nutrition or protein or energy requirement, or to start or to increase or stabilize. Okay. Now aim for at least 1.3 gram per kg of per day of protein, adjusting as needed for specific conditions or higher protein requirements. Higher again, we have discussed that 2 gram per kg per day should be reached at some point of time in burns or trauma patients. But definitely, if required, we can increase to certain extent. To certain extent means maximum is 2.5, but recommended is up to 2 gram per kg per day only. Now switch to parenteral nutrition. When we have to switch, if enteral nutrition is not feasible or sufficient, initiate parenteral nutrition after 3 to 7 days, starting with a lower protein dose and increasing as tailored. So if enteral nutrition is not feasible or sufficient, then initiate parenteral nutrition after 3 to 7 days. Again, here same point, to start with lower protein dose and increasing as tolerated. Why I'm saying? Because we don't want any complication, or patient should not go in intolerance, and there should not be any further complication or side effect. We can say that sepsis is major thing, or septic shock is something which we are always afraid of. So monitor for complications associated with parenteral nutrition, such as infections and metabolic imbalances. Monitor for complications and associated with parenteral nutrition, such as infections and metabolic imbalances. So there is one more classification that is as per the demand of the patient. That is, specialized protein formulas are designed to meet unique nutritional needs of patients with specific medical conditions. Here's a detailed classification of these formulas for various conditions. Renal patients, that is low protein formulas designed for patients with chronic kidney disease who are not on dialysis. These formulas contain lower amounts of protein to reduce burden on kidneys. There are high protein formulas for patients on dialysis where protein needs are increased due to losses during dialysis process. So two aspects: low protein formulas for CKD patients but not on dialysis. But high protein formulas are used for patients on dialysis where protein needs are increased due to losses during dialysis process. This is something which is we have to remember. Why? Because patient is on dialysis and patient is admitted to ICU with some disease or some critical illness. At that point of time, patient protein requirement has much increase, including energy. So these things should be met. Definitely start with low protein calculated, whatever we have calculated. Next is liver patient. Formulas for hepatic encephalopathy. These contain higher amounts of branch chain amino acids and lower aromatic amino acids to help manage hepatic encephalopathy. So here all target is to reduce hepatic encephalopathy and to reverse whatever disease condition is, if possible, definitely. But here branch chain amino acids is something which we always have to prefer. Now, general liver support. Formulas with moderate protein content often enriched with nutrients that support liver function. Heart patients, yes, there are cardiac formulas in market which we are also preferring, that is low in sodium and saturated fat and enriched with heart healthy fats, that is omega-3 fatty acids. These are more or less could be similar to renal patients and can be used in the renal conditions also. Now, whenever we are dealing with heart patients, there must be pre and post or many of times cardiac conditions like plasty or bypass or some cardiomyopathy or failure. These patients might have another comorbidities like diabetes or kidney related or hypertension or simply high cholesterol. In that specific patients, particularly renal, these are somewhat similar kind, and these formulas, I mean cardiac formulas, can also be used in renal patients. Post-operative patients, high protein, high calorie formulas. Post-operative patients require high protein, high calorie to support wound healing, recovery, prevent muscle loss. There are immune enhancing formulas which are also preferred in post-operative patients. Whenever we are dealing with major surgeries or GI surgeries or cancer-related surgeries, at that point of time, patient requirement of protein or calories or energy or immunity should be addressed. So these immune enhancing formulas contain arginine, omega-3 fatty acids, and nucleotides to support immune function and recovery. Now, coming to the burn patients have very high protein and high calorie requirement. Formulas to support tissue repair, immune function, and overall recovery. Additional factors like glutamine, zinc can be included for better healing and counter severe catabolic state. So these additional factors like glutamine or zinc can definitely be added for better healing and counter. But main crux is only and only very high protein and high calorie. Whatever other factors we are saying or we are adding, these are always adjuvants to protein and calorie. We definitely going to require them, but main crux is high protein and high calorie and high energy in burns patients specifically. Cancer patients, yes, definitely. Again, immune enhancing formulas often contain EPA, DHA to help reduce inflammation and maintain muscle mass. Here, examples of impact advanced recovery and ensure live that for cancer patients we are using. Again, high for protein and high calorie formulas to address increased metabolic needs and potential weight loss. In neuro patients, formulas with specific nutrients. These contains nutrients that support brain function, such as, again, omega-3 fatty acids, antioxidants, and certain vitamins. Diabetic patients, diabetic specific formulas are designed to manage blood glucose levels, often with a lower glycemic index and control carbohydrate content. This is the most commonly used formulas we are using in critical illness because many of patients we are facing are diabetic or hyperglycemia. Pulmonary patients, these pulmonary specific formulas are designed to reduce carbon dioxide production and support respiratory function, often with higher fat and lower carbohydrate content. Severe sepsis or ARDS patients. Whenever we are dealing with this pulmonary patient, this is very important point when about severe sepsis or ARDS or septic shock, because these pulmonary patients always or many of times land up in ARDS or any pulmonary condition where it could be life-threatening or the vital instability or this sepsis and ARDS. I mean to say this sepsis, why I'm saying sepsis, because these are very vulnerable patients, and even if there is small insult in terms of infection in lungs, I mean to say LRTI, URTI, whatever, these patients give very less time and deteriorate very rapidly. So here ventilator is something which is unavoidable and we have to deal with the ventilator. In fact, ventilator is going to have lots and lots of impact on mortality or morbidity. So our strategy will be definitely dependent on ventilator. This is always important factor because in pulmonary patient, ventilator is something that our strategies are definitely dependent on ventilator. GI disorders, elemental and semi-elemental formulas contain hydrolyzed proteins and are designed for easy absorption in patients with malabsorption issues. Here, along with that, fibers are also important. So we need formulas which contains fiber. Why? To support bowel health and function. Elemental and semi-elemental formulas, definitely those are important. But here hydrolyzed proteins, that means these proteins or peptides should be easily absorbable. That's why we require hydrolyzed products. Critical care patients, that is immune enhancing and metabolic stress formulas. These are designed for critically ill patients to support the immune system and manage metabolic stress. High calorie formulas, again, for patients with increased calorie needs due to critical illness, we require high calorie immune factors or metabolic stress formulas include all those factors which will help. But again, protein requirement and energy requirement will be on higher side. Geriatric patients, formulas for older patients that is high in protein and calories and often contain added vitamins and minerals to address age-related deficiencies. Pediatric patients, we definitely see less patients in pediatric, but still specifically designed to meet nutritional needs of children, including those with specific medical conditions. I think pediatric intensivists will be the better people to explain this thing. Wound healing, wound specific formulas, high in protein, arginine, and other nutrients that support wound healing and tissue repair. Patient with sepsis, omega-3 fatty acid containing formulas to modulate immune response and reduce inflammation. Obviously, whenever we are saying there is omega-3 fatty acids or other factors, these will be only adjuvant to the treatment or the main crux of the treatment. But yeah, definitely all these have positive impact on management, whatever we are doing, particularly in sepsis or any specialized population targeted. Patients with inflammatory bowel disease, that is anti-inflammatory and easily absorbed formula. Again, hydrolyzed protein are preferred over here. To manage inflammation and ensure nutrient absorption, we require anti-inflammatory and easily absorbable formulas. This is one of the nutrition protocol based on practice guidelines which we follow. To start with patient admission, check if patient is hemodynamically stable or not. If not, then wait for stabilization. If stable, then screening and assessment of nutrition status that we have already seen, but here already mentioned that 2A, that is nutrition assessment, will be history, disease state associated with risk of malnutrition, recent weight loss, that is 5% of body weight in 3 weeks or 10% of body weight in 3 months. Decrease food intake before admission, history of alcoholism, of drug abuse. Assessment of present condition, that is disease associated with hypermetabolism and prolonged catabolic activity, multiple injuries, burns, sepsis, MODS. Signs of malnutrition on physical examination, that is cachexia, muscle atrophy, and edema, BMI. These are always our clinical or nutritional assessment, which we have to assess not only on day of admission, but we can continue whatever on daily basis, whatever is possible. Now calculate the nutrition requirement, that is energy protein requirement. Energy definitely 25 to 30 kilocalorie per kg body weight of day. Protein 1.2 to 2 gram per kg of body weight, can be higher in trauma. Definitely, again, our clinical assessment, nutritional assessment, whatever disease is going to be important for individualized our management as per the patient requirement. I mean, individualization is very, very important. Our clinical judgment will be very, very important. Even if we have all those guidelines, we have reference numbers, still, we should always individualize and then discuss and then to start. Okay. Can enteral feeding be initiated? Yes or no? If no, initiate parental nutrition if patient is malnourished. If yes, then oral or tube feeding. If patient is able to take oral, monitor patient's intake. Start enteral nutrition or a liquid diet or some soft or some semi-solid if requirement, if not made. Okay. So you can definitely have oral oral feed. I mean to say liquid or soft diet or semi-solid if patient is able. If not, then definitely enteral nutrition will come in picture in oral point. Tube feeding, initiate enteral nutrition, that is tube placement, start within 24 to 48 hours of admission. Start early, we have discussed, advance towards full goals gradually. Start with standard polymeric formula. Tropic feeds 10 to 20 ml per hour if we have to start. Unless formula feeds are always better to reduce not only the infection, but also they are digestible. Now, check the tolerance. How we are going to check the tolerance in enteral feeding? Patient tolerating feeds start, if patient is definitely tolerating feeds, then we have to go ahead with it. We already seen that regurgitation or nausea or vomiting, then aspiration, that is presence of feeding formula, or or if there is diarrhea or loose motions more than 3 per day, definitely it is again a reference value. We don't have to we just have to manage and we don't have to stick to this number. Okay. If patient is not tolerating the feeds, evaluate symptoms. And if patient is unconscious, then check aspirate. This already I explained section 3. Then check other reasons for intolerance. That is antibiotics or sorbitol, infections, osmotic diarrhea, and other medications if responsible. Measure to improve the tolerance. What are the measures what we can use? Is use prokinetics, head of bed at 30 to 45 degrees. Use a post-pyloric route of feed to avoid ventilator-associated pneumonia. Use chlorhexidine mouthwash. These are routine things which we have to do, but these will play major role whenever we are having this having this assessment. Okay. Then switch to semi-elemental formula whenever needed. In summary and conclusion, the ISPEN guidelines recommend a tailored approach to protein and energy provision in critically ill patient. Start with conservative energy provision, closely monitor patient response and adjust nutritional support based on individual needs and tolerance. So this I will end my presentation over here, and in the end I would thank you very much, and in the end I would like to appeal for world peace. Over to you, Dr. Jairam.
Thank you, sir. Thank you for wonderful session. Now, if anyone has any questions in your mind, please ask. I'm sure sir would be pleased to answer them. Shall we take questions, sir?
Yeah, definitely.
Uh, Sir, after how much time the albumin rise in seen in ICU patient?
Albumin rise, you mean to say after giving this
Yeah, after giving.
one second. Is this the same question from chat box? No.
Yeah,
Okay. So I will say whenever we are giving this albumin from IV or this enteral route, definitely slowly after 24 to 48 hours of next albumin level, there should be some rise if there is no loss. But that is not that is not some uh, perfect value that within couple of days it should rise. It will just a symptomatic thing. I mean to say, if we are not treating the cause, then it will be and there is some increase in albumin that will be only temporary. So uh, even if we are expecting some rise, that will happen within first of 2 to 3 days. Some of times it may happen early, but after 2 days definitely there should be some rise.
okay.
I think should we go ahead with the chat box questions?
Yeah, sir.
So first is bowel sounds are no longer used for initiation or monitoring of enteral nutrition. Guidelines over 2 decades have downplayed bowel sounds. Yes, definitely. I totally agree. And this point is also not included in our current or latest ISPEN guidelines. It is just a part of our clinical judgment. Why I'm saying that? Because in post-op patients, even if it is uh, GI surgery or not non-GI surgery, but because of anesthesia, there could be some slowing or there could be some hemodynamic instability and patient could be on inotropic support. So definitely we should include it as a part of our clinical assessment. But yeah, definitely it is not included in guidelines and it is not something with which we can take a decision. True, that is correct.
Okay.
We don't use human albumin nowadays. Yeah,
Hmm.
that's true. That is for formulas we are already having in market. IV albumin should never be used in nutrition therapy. There is absolutely no reason to measure serum albumin's level. Again, it is not a recommended, not a decision maker, but whenever there is need of albumin in other aspects of treatment or management of patients, further treatment, then definitely we can use it as a clinical assessment. That's what only I can say. But yeah, it is totally true that it is not recommended to I already mentioned this thing in presentation that whenever we are doing all these parameters or biomarkers for any other reason and we are having those reports, sometimes couple of times within a span of 2 or 3 days or a week, then definitely we can use it as an assessment. Why should we give high fat formula in pulmonary conditions? Now here is something which I already mentioned, that our all strategies depends on some ventilator. I mean to say these pulmonary patients are having lots of disbalance or imbalance or abnormalities in CO2 or oxygen or ratio is always compromised. So at that point of time, we always have to individualize the patient and act accordingly. Definitely, fat formula, there are multiple aspects, sometimes obesity, sometimes BMI, and all these factors in taken consideration, it should be individualized. I already mentioned that our guidelines are definitely perfect ones, but we have to individualize the patient, and definitely even if there is high fat formula in the market, we always have to individualize, and then only we have to give, because fat formula itself might have some trouble. But yeah, fatty acids are something which we should use as a important part of pulmonary formulas.
Next is what is done in multi-organ admission, hepatic and renal, for example.
Okay. So there are renal specific formulas, there are hepatic specific formulas. So again, I will only say individualization and take the discussion with a particular consultants or other departments, including gastro or hepatic, renal, and most important thing, dietitian will guide us over here. I request some of dietitian should answer this question. Or
Yes, sir.
anyone.
In hepatic, we already use some hydrolyzed protein, and in renal, there is, if patient is on dialysis, we use high protein formula, and in acute stage, we use low protein formulas.
Yes. Other than that, BCAA, if there is a scope of inclusion, then definitely we should think of that. But yeah, protein is something which we should focus on, and along with that protein, energy expenditure and requirement should be met. Obviously, to start with low. Pulmonary formulas, although available in India, is no longer recommended. RQ gets elevated with CO2 production only when high CHO calories are given, not available in most countries. Agreed. I already given answer to this question, I think. Dr. Jayanti, 40% of CHO should be initiated. That's why to increase the calories, we need to give high fat for COPD patients. More carbohydrates will increase the high CO2 production and elevated liver enzymes. Agreed. So that's what I'm saying. High fat is something which cautiously or if needed to avoid, we should avoid. Agreed. Next, hydrolyzed protein, is it really still available? Yeah, it is available. What can be done in a non-affording case to admitted in ICU? I will try to avoid comment on this thing, because see, what I will answer in what we do in our setup. I'm working with Fortis Hiranandani Vashi Navi Mumbai. So we have lots of tied up patient. I mean to say paired patient. I mean to say BRC or CNGC or ONGC or ECH, sometimes NMMC, that is charitable free patients, or sometimes you can say JNPT, or lot many patients. So you can say RCF or railway patients or police patients. These patients definitely have their insurances, but this protein element or many of time this nutrition factor they do not cover, and they explain to their patients. I mean to say relatives. In spite of that, other than that, we have provision in our hospital to have financial counseling about these products, that even if they are insured people or insured patients, they have to bear the charges of this nutrition factor. And definitely after seeing our work or after explanation or after our counseling, many of patient, definitely I cannot say 100%, but many of patients understand and they do they bear these charges. I can only answer this thing whenever we are having non-affording case.
Any
Uh,
other questions?
It's a pity that insurance companies pay for parental nutrition, but yeah, it's a very big debate, boss. No one can answer this question. That's a good point. I think I request Dr. Jairam to have a few more words on this topic. I think he must have more to say uh, with his experience.
Yes. So whenever we start the nutrition in the critically ill patient, we always have to assess the requirement of the nutrition in every patient in the critical care. So one of the standard method to assessment of the critical care nutrition is the indirect calorimetry. But many places it is not available. But we generally use the indirect calorimetry for every patient. We have that indirect calorimetry even for ventilator patient as well as the spontaneously breathing patient also we have. So we always do indirect calorimetry for every patient on admission, on every day, every third day we repeat the indirect calorimetry of the patient. And we found that it is very useful to monitor the nutrition intake of the patient. Initial part of the critical illness, the requirement of standard requirement of we calculate as a 25 to 30 kilocalorie. It is not required in many patients. The requirement is very low in severely critical ill patient. We found that it is almost 10 to 15 kilocalories only in initial 7 days. Then the requirement gradually increases later on for this patient. If we give much more protein intake or much more calories to the critical ill patient, the ventilatory support will be required for a longer period. When we do the indirect calorimetry and we reduce the calorie intake of this patient, this patient can be weaned very early stage. Once the patient is shifted to the out of the ICU and it is at about to discharge, the requirement of the calorie intake is really high. The patient goes into hyperphagic situation and they require up to 30 to 35 kilocalorie per kg energy requirement as per indirect calorimetry, as we found in this. So even though it is said that the whenever we have to provide some calories to the patient, we should not calculate the calories provided by the proteins. So always start with the protein gradually, and we have to increase day by day according to the clinical response of the patient. So that only I have to tell. Thank you.
I
So
request
any question from Monica? Is there any other question from the audience?
No, sir. One last question. How much does indirect calorimetry cost to the patient?
you are only better person to answer this, Monica ma'am.
So in our hospital, so indirect calorimetry is a device that is allotted for the ICU. So we don't charge anything to the patient. So we have to just get the idea about how calorie requirement is required. So there is no extra burden on the patient because it is fixed device. We use that mask. We don't use the non reusable things. All are reusable things. The mask is required only and that tubing.
Yes.
So, and with the ventilator, we have the gas analysis sensor in the ventilator inbuilt. So we use that only. So it gives the IC data on the ventilator also. So no extra cost to the patient.
Okay.
Any other question?
No, sir. There is no questions.
So thank you, Swapnil, for such an excellent and very informative presentation. Also, thanks Dr. Monica Patel, madam, for moderating this session. Before giving the vote of thanks to others, I would like to invite Sampan Tang for the from the Proju. He want to play a small video on the Proju. He is the sponsor of our webinar.
Thank
The
you,
over to you, Sampan.
thank you so much, Dr. Jairam and Dr. Swapnil, for the wonderful session. It was indeed very knowledgeable. We as a manufacturer also learn a lot of things when we be a part of such a conversation. And I feel there are a lot of areas where we can collaborate and help bring better accessible products to the patient, thereby assisting you for better treatments. So I will just go through a short presentation showing what we have done achieved so far. So is my screen visible?
Yeah,
Yes.
Yeah. So Pro Nourish Academy is our agenda where we try to bring in some sessions which are very knowledgeable to all the audience. So this is like a small group. Every time we try to have such sessions where we touch different points which are very critical. So this is a brief summary of what Projiv is. Projiv essentially has been niche company. We started in 2014 as Niche Life Sciences, where we manufactured products and exported across globe. In 2015, we founded this company called Care Healthcare, which is the manufacturer. In 2020, we expanded, we increased our manufacturing capacity, and we shifted to our new manufacturing plant where we are currently. In 2021, we came up with this brand called Projiv. And Projiv, as a sense, Pro means protein and Jiv means Jivan Sattva. That is our philosophy behind the brand name of Projiv. So we are trying to bring in more novel and niche products wherein it helps all the doctors and the entire medical fraternity to give equal importance to enteral nutrition as we have the importance of parental nutrition. And in 2023, we launched Projiv. We have a group of people who are very much passionate and very like our entire team is of people who are from pharma, science, and marketing background. We are trying to inculcate the best of the products. So our agenda is to bring in products which are essential for you as doctors to help your patients recover faster. So if there is any scope where you need a help, you need to develop a product, please feel free to reach out to us. We are there to help design products as per the requirement. That's it from my side. Thank you so much.
Sampan is over.
Yeah.
Okay. So thank you, Swapnil, and thank you, Monica Patel, ma'am, for this wonderful session. I would like to thank ISPEN and Dr. Sanjit sir for allowing the ISPEN Mumbai branch to conduct such a webinar. I would also like to thank you, Proju, for sponsoring this educational session. We'll expect from Proju for further participation in the educational activities of the ISPEN Mumbai branch. Many more webinars of the ISPEN Mumbai branch will be in the line, and we will tell you the next webinars as we have decided. The next webinar will be held on 16th August, which is on role of glutamine in the ICU. The link for the next webinar will be shared shortly in the on the WhatsApp as well as on the Facebook page also. Uh, Also, the many more webinars. We are planning every fortnightly webinars on the nutrition in the critical care. So do attend all the webinars. And with this, I would like to conclude this session. Thank you. Thank you, everyone. Thank you for the participant, and thank you to the Swapnil and Monica madam for the participation.
Thank you. Thank you very much to everyone involved in such a platform, including Projib and Dr. Sanjit and ISPEN team. I mean, not only Mumbai, but national team who had given us opportunity. Thank you. Thank you very much.
Thank you.